Welcome everybody. My name is Amit Pawa. I'm the president of RAUK, and on behalf of RAUK, Regional Anaesthesia UK, our speakers, our sponsors, we welcome you to our first ever webinar. And today we're going to be talking about ambulatory spinal anaesthesia. Please feel free to tweet during the meeting using the hashtag RAUKSpinal. And we would like to thank our sponsors, both B. Braun and Synthetica, for supporting this webinar. Without them, this would not have been possible, and they've been amazing at getting this off the ground very effectively. We've only had a sort of a lead time of a short period of time, and they've managed to get things going very smoothly for us. Before we start, we do have some housekeeping to discuss. Today's webinar will be recorded, and it will be available to view on the RAUK website shortly after the webinar has ended. The website link is shown there for you. You will also have the opportunity after each session to submit some questions. And if you have a look on your control panel, which hopefully all of you can visualize over there, there's a questions section. If you click into that box and submit your question, I've always seen there's been 3 or 4 questions submitted already. I'll be able to see those, and I'll be able to go through those and ask those, or at least some of them, at the end of the session. The other thing to talk about is the fact that there will be handouts available, and if you look again on your control panel there, you'll see 3 handouts that are visible, and those handouts are also available via the RAUK website. So now on to this evening. We welcome over 2,200 registrants from all over the world. Some of you are tuning in live, and I can see we've got a good fair few number. We've got about 600 or 700 of you tuned in live. There will be a large number of those people that will be watching it on playback all over the world, so we welcome each and every one of you. The COVID-19 pandemic has affected the world and impacted many of us and our loved ones in a way that we probably could never have predicted 6 months ago. As many of us now are looking forward to ways to start delivering anaesthesia care in this new world, it's become apparent that regional anaesthesia has the potential to play an important role. I'm delighted this evening that we have 4 excellent speakers who will together discuss how and why regional anaesthesia may play a role, and they'll cover important subjects such as sustainability, efficiency, and how to implement an ambulatory spinal anaesthesia service. Before we start, however, we'd like to run a very quick poll that will now appear on your screens, and the poll should be running live now. If you just click on the button on your poll, you'll be able to answer this question: how confident are you to use short-acting spinal anaesthetics? If you click one of those 3 options right now, and after about 10 seconds we'll get the answer. So how confident are you to use short-acting spinal anaesthetics? Select one of the following: very, not at all. And this is certainly one of the reasons why I'm fascinated about taking part in this webinar. This is something that I'm hoping to learn a lot more about, because certainly at the moment this is not something within my skill set, so I'm hoping that we'll all get a chance to learn together. So the results of the poll, so that's interesting. We've got 41% of people saying they are very confident, but the majority not at all or not very confident. Okay, so without further ado, I think we'll start off with our first speaker. It gives me great pleasure to introduce Professor William Harrop Griffiths, who I'll give you a little bit of an introduction, although he's a man that doesn't need much of an introduction. He qualified from Oxford and St Thomas's Hospital, my alma mater as well. And after training in London and Seattle, he was appointed as a consultant anaesthetist at St Mary's Hospital since 1991. He has a very active role in the Royal College of Anaesthetists. His specialty of interest, not surprisingly, is regional anaesthesia, and he's chair of the Clinical Quality and Research Board and also the ACCA lead. His other interests, worryingly for me, because I wrote a paper with him recently, are English grammar, bicycles, and motorcycles. So it gives me great pleasure to introduce Professor William Harrop Griffiths.
Amit, thank you very much indeed for that wonderful introduction. Now, when we thought of the title for these talks about 4 weeks ago, it seemed like a very good idea to choose an opening title of why choose regional anaesthesia in the COVID-19 recovery phase, only to find that we're probably not sort of in the COVID-19 recovery phase. I'm going to talk more, not so much about why choose regional anaesthesia in the COVID recovery phase, but why choose regional anaesthesia right now? Now, before I launch into that, I want to admit my competing interests. They are that I've received honoraria from both B. Braun and Synthetica for educational activities, and that I'm a regional anaesthetist whose passion borders sometimes on absolute obsession. So you should think of that carefully before believing every single word I say. But I'm going to start out with a simple clinical story and a real story of two real anaesthetists. I work every other week in a specialist private orthopaedic centre in central London, and this particular centre prides itself hugely on doing almost all its cases as day cases. Even quite major orthopaedic surgery, it does as day cases. And every other Monday morning, I'm in one of the two operating theatres. I'm doing a shoulder list, and my friend and colleague, another fellow grumpy old git, you know who you are, Mark Kenny, is in the other operating theatre doing a foot and ankle list. I do all my cases under regional. He did all of his cases under general. And we had the standard banter, which is regional versus general anaesthesia. He said that fundamentally regional anaesthesia was a form of perversion, whereas he pragmatically gave general anaesthetics, knowing that these patients could get out, walk out of hospital, hobble out of hospital later on that day. And then COVID-19 happened, and suddenly things have changed. And I can say with pride that this person now gives a substantial majority of his foot and ankle procedures under short-acting spinal anaesthesia very, very successfully. And that's what's really happened, I think, in a lot of places, that change of a number of different sorts has been driven by COVID-19. Now, one of the reasons behind significant change is this wee beastie here, SARS-CoV-2. And we think, and remember, there's a lot we don't know about this virus, but we think it's spread in one or two or three different ways. One is by contact, direct physical contact with an infected person's phlegm or spit, or touching that once it's landed on a surface and bringing it to yourself. Another form of spread is by droplet. These are droplets of infected fluid from the upper respiratory tract of 10 microns or more, called droplets, and they have what's called a ballistic trajectory. They travel, but they're pulled down by gravity because they're quite heavy, and they tend to go no more than 2 meters. But the third and the most relevant form of potential spread to this talk this evening is airborne spread. If you put a very, very high velocity gas flow across a thin layer of liquid, you can create an aerosol. Now, aerosol, less than 10 microns in diameter, each particle can sit in the air for a considerable time as an aerosol and can infect other people. It can float for a very long time until eventually the tiny droplets desiccate and drop to the ground. And therefore, there is an accent on aerosol generating procedures, or AGPs. Now, if you go to NHS England improvement guidance, and you go to Public Health Education and Public Health England guidance, you will find the phrase potentially infectious AGPs for COVID-19. Because that is not completely synonymous with AGPs. There are some aerosol generating procedures that create an aerosol that are highly unlikely to cause the transmission of COVID-19. And an example is diathermy. So diathermy does create an aerosol. It creates a blood aerosol, but COVID-19 virus is not fundamentally a blood-borne virus. It spreads by the respiratory tract. Yes, it's been found in blood. Yes, it's been found in feces. But there is no great concern about these aerosols that are not created from the upper respiratory tract. If you want to know what is considered an aerosol generating procedure in this country, in the United Kingdom, you go to that web address and you will find that document published by Public Health England. And it's worth looking at this particular phrase that's on the top page, the front page of that document. It says uncontrolled if printed. And it means if you take that document off the web onto your computer or you print it out on paper, it no longer definitely represents the latest version. Because Public Health England produce new versions not infrequently, and they don't always shout about what's in the new version. So you should always go and look at it on the web. This is checked today, the current list of aerosol generating procedures that can transmit COVID-19 disease. I'm not going to go through all of them, but I am going to call to your attention the third one, manual ventilation, and the fourth one, tracheal intubation and extubation. The other one that's worth looking at slightly lower down in the list is high-speed cutting in surgery or post-mortem procedures, but only if it involves the respiratory tract or paranasal sinuses. This document refers to a second document produced by NHS Services Scotland, and that's essentially a semi-structured literature review of the evidence supporting the production of aerosols in certain procedures and whether they can transmit COVID-19. This is what they say. They found no strong evidence for any aerosol generating procedure transmitting COVID. They found no moderately strong evidence. At best, they found weak evidence. This list provides weak evidence, and you can see there manual ventilation and performing tracheal intubation. Then there's an even longer list of procedures for which there is no evidence that they can produce aerosol that can communicate COVID-19. The first 5 on the left are highlighted in blue because they are actually aerosol generating procedures within Public Health England's document, but there's no evidence for them at all. That does not stop them being treated as AGPs, but it is being honest about the fact there is no evidence at all for them. So if you look carefully at that, you'll find there are some things that are not AGPs according to Public Health England. Tell your surgeons. If you are surgeons, tell yourself. Powered saws and drills outside of the respiratory tract, not an AGP. Diathermy, no. Laparoscopy, no. Laparotomy, no. Pulse lavage, no. These are not currently in the UK AGPs. Public Health England stays remarkably quiet on supraglottic airways. It doesn't commit itself one way or the other. And so as a result, we have to take certain things as aerosol generating procedures. Now, I will reveal to you that there are some ongoing studies that may suggest that some of the things that we think are AGPs are not in reality AGPs. I'm not going to call them out which ones they are, but they are of relevance to anaesthetists. They are being examined scientifically. There will be changes to that list, I'm confident, in the next few weeks, so keep an eye on it on the web. But for the time being, airway manipulation under general anaesthesia is an AGP. However, breathing spontaneously with a capno mask is not an AGP, and regional anaesthesia with no sedation, mild up to moderate sedation without coughing is not an AGP. And one of the problems is that AGPs come with a deal of baggage. Airborne precaution, I don't like wearing airborne precaution PPE. I will wear it. It takes a while to put on properly. It takes a while to take off properly, and it's unpleasant to wear for any particular time. But there are other things that AGP causes. For some reason, we're not allowed to give anaesthetics in the anaesthetic room anymore. We have to give in the operating theatre. And although there may be logic behind that for a patient with rampant COVID, there is less and less logic in that change for a patient who has had a series of negative antigen tests or perhaps been self-isolating at home. It just seems to be a standard response by some theatre managers. When anything goes wrong, we're not allowed to use the anaesthetic room. But the most important issue from our point of view is the fact that you have to wait for aerosol clearance after an AGP. PHE says 20 minutes. In reality, it's 5 air clearance times if you measure the air circulation rate in your operating theatre. So if it's 20 air circulation, air exchanges an hour, each one's 3 minutes, 5 of those is 15 minutes. But you need to know what your air exchange rate is. You've got to wait that at the beginning of general anaesthetic and at the end. But this is the other bit of baggage with AGPs. And I don't know whether it's happening in your hospital. It's certainly happening in my hospital. There is happening, it's nobody's fault, but there's a very relaxed attitude. And if everybody doesn't get a 45-minute break between cases, people get slightly upset. Everybody's relaxing. It's a kind of a mindset which has come about because things take so long. We need to bring back a greater sense of urgency. The reason to use regional anaesthesia 3 minutes out, not long to go. Planned surgery ground to a halt in the UK during the COVID surge. We've got to get going again. We could perform, under the current rules, a lot more surgery safely if we used more regional anaesthesia, because we know that because the regional anaesthesia and an awake or lightly sedated patient is not involved in aerosol generation, that you don't need that downtime to clear aerosols and airborne infection. Back on Friday, the head of the NHS, Simon Stevens, wrote this letter to all the people who run the trusts and hospitals within the UK. Look at this. Having carefully tested the feasible degree of ambition with a number of trusts, we're now expected to re-establish services to deliver in the NHS. In September, at least 80% of last year's activity for overnight electives and for outpatient day cases rising to 90% in October. That's compared with last year. You've got to be at almost 100% in 2 months' time. Notice the wording. They've tested the feasible degree of ambition. They haven't tested the degree of ambition. It's the feasible degree of ambition. If we're going to get anywhere near there, we'd start to need to do things differently and more effectively. There are many benefits to regional anaesthesia. Genuinely, I'm not going to list them. But even outside of a viral pandemic, there are superb reasons for making regional anaesthesia your first choice. I've been doing so for the last 30 years. But now there is an extra pressing need to increase turnover, to get those patients who've been waiting, while waiting on the waiting list, getting sicker, their conditions getting worse, getting their planned procedures done. And regional anaesthesia, I put in for once for the skeptics, can be a lot quicker than general anaesthesia because of the current regulations about the management during a COVID pandemic. There will be legacies to COVID-19. It may be that video conferencing will be seen as having come of age, and we'll be doing this sort of thing a lot more frequently. We'll look back and say that's when working from home became the norm, when cycling got really popular, and when waistlines expanded and livers got severely punished. Hopefully, we'll also look back on COVID-19 and say it was the time when general anaesthetic Luddites gave regional anaesthesia a go. Now, it takes a lot of time to learn how to do a PEX 15 or a tequila 26 block or whatever the latest trunk block is that Amit Pawa was talking about, but anybody can do a spinal. Many planned and emergency procedures take place below the waist, and spinal anaesthesia and day case surgery mix. I could go on, I'm not going to, 1 minute to the end. With Amit and Alan, we wrote an editorial, not yet in paper, but it's there online, the British Journal of Anaesthesia, talking about all the issues related to regional anaesthesia and COVID. I would encourage you to read it. And it says, in a crisis, be aware of the danger, but recognise the opportunity, from John F. Kennedy. And the organisations did seize the opportunity. The OAA love epidurals, and they said, put in the epidurals early. The DAS, they different airway society, love video laryngoscopes. So they said, use video laryngoscopes all the time. Regional anaesthesia, who love doing blocks, say use regional anaesthesia. And the Society for Intravenous Anaesthesia, who were told that they couldn't give any intravenous anaesthesia because there wasn't any propofol or Remi, were upset about it. But watch out, because the regional anaesthesias will seize the opportunity. But I want you to seize that opportunity. If you're not a regional anaesthesia obsessive, it's a chance to show yourself that it can be efficient and effective, that you can use spinal anaesthesia reliably, even in day case surgery. And hopefully this change will outlast the COVID pandemic. Time for me to shut up, answer your questions, and allow other people to speak. Amit, over to you.
Well, thank you very much, William. That was a wonderful way to start our webinar. And as you might imagine, I've got a whole host of questions coming in. The first question is spinal anaesthesia better than a general anaesthetic in patients with COVID-19?
Do you know, it would be really for me to say, yes, of course it is, but you cannot be as general as that. This is an individual patient discussion. This is an individual patient decision. And I'm going to stress it's a patient decision. I personally think that all things being equal, it is of benefit to the patient to have a spinal where it is a feasible alternative. It is certainly possibly a benefit to the overall turnover of patients in the hospital. And you could even argue it's a benefit to those healthcare workers looking after that patient, because there are no aerosols generated during the procedure. If it's not a head and neck procedure, it's a spinal, it's not going to be. But it's up to the patient. You evaluate the patient, evaluate what's best for them, tell them what you think genuinely is the best for them, allow them to take the decision. One of the questions that came up is, can you tell that patient that they may benefit healthcare workers if they go for a regional rather than general? I personally believe you can, because patients are lovely people, and they usually say, God, yes, you're doing a wonderful job for me. I want to help you every bit I can. I'll go for the spinal. Long answer, short question, but there you go.
Another interesting question. Do you think your colleague will go back to giving general anaesthetics only once this is all over, once the COVID-19 crisis is all over?
So I've had a word with the ODP, and he's going to hide all the propofol, so it's going to be very hard for him to go back to general anaesthesia. Do you know, this is going to be the really, you know, I was talked about lasting legacies. I genuinely think, I'm not sure whether he will, but I think a lot of people who thought, you can't use spinal for a day case, it doesn't work. The fact that they have done it and shown to themselves that it works, that it's reliable and effective, hopefully will start to turn it around in some people's minds, and that many, perhaps not all of those who've made that change, will continue with that change. I personally believe it's for the benefit of the patients, but that's for individual anaesthetists to decide, not for me.
One more question, I think, before we go on is, are you biased towards regional anaesthesia when you're consenting the patient? And a follow-on for that is, how ethical is it to consent a patient for a procedure when we deem it's the healthcare worker that may be more to benefit?
The answer to that is I carry with me a bias, but the GMC is quite clear. Although you must give a balanced view, you must give the patient the alternative treatments, the risks and benefits of the treatments. You as a clinician are allowed to express an opinion. Your opinion may be that general anesthesia is the only thing to give, or it may be that regional anesthesia is fantastic, but you are allowed to say that, in my opinion and experience, I think that this is the better way, or this is the way that I might actually do it. So you are allowed to say that, you are allowed to express an opinion. What was the second part of that question, Amit? Remind me.
Is it ethical to consent a patient for a procedure where it may be the healthcare worker that's the more likely to benefit?
There is no definite pronouncement from the General Medical Council. There are equivalents across the world. That is for you to decide. I personally think that you shouldn't use it as a primary way of persuading a patient to have one or another. But if that patient is balanced on the cusp, I think a reasonable patient would like to know all the full situation, and as long as it's couched correctly and it's balanced, why not? Why not?
Perfect. I think we'll probably end it there. There are a lot more questions that have come through for Professor Harrop Griffiths. What we'll hope to do at the end of this webinar is to answer some of those questions, and we'll put out a whole answer pack with answers to many of these questions. So some homework for you, Will, if that's okay. Thank you very much for a wonderful presentation. It now gives me great pleasure to introduce our second speaker. So Dr. Will Rattenberry is a new consultant anaesthetist. He's recently been appointed at Nottingham University Hospitals. He was the first author of the BJ Education article that you will see as an attachment on our RUK website and on this webinar, Spinal Anaesthesia for Ambulatory Surgery. And he's also worked alongside the Association of Anaesthetists to successfully campaign for the removal of plastic hook ring from the anaesthetic face masks. He's also, of interest to us, recently co-organised the Association of Anaesthetists online seminar on environmentally sustainable anaesthesia. Will, you're going to be talking to us about implementing a greener recovery with spinal anaesthesia. Over to you.
Thank you very much. Without further ado, I have absolutely no declarations to make, and the overview of the next 15 minutes is to talk briefly about the climate and environmental emergency, to focus our minds, revise the environmental impact of anaesthesia. I hope some, hopefully not all of it, the talk will be familiar to people, and specifically focusing on what are the benefits to the environment of spinal anaesthesia and ambulatory surgery. We live on a vulnerable planet of finite resource. This image of the Earth from the Apollo missions shows just how small our atmosphere is, with 80% of the gas in the first 10 kilometers. It is something which we're proving is extremely easy to pollute. We've known now since the late 1800s, thanks to a Swedish scientist called Arrhenius, that carbon dioxide can cause a greenhouse effect leading to global warming. And we know that current levels of 414 parts per million are unprecedented thanks to ice cores taken from Greenland and Antarctica. Temperatures are rising. We're already at 1 degree Celsius above the common baseline. To put that into context, the last ice age was only 5 to 8 degrees Celsius lower than that common baseline. The change is already apparent. 8 of the last 10 years, 8 of the last of the hottest years have occurred in the last decade. Wildfires are on the rise, as we've seen in Australia. Extremes of weather, such as Typhoon Haiyan, are more common, and this is in part thanks to warming oceans. And the ice is melting. This is an image of Greenland, where NASA have estimated almost 300 billion tons of ice is lost each year. But the environmental impact of what we are doing goes beyond just simply a warming planet. Air pollution, water pollution, plastic in the oceans, and loss of natural habitats and the effect on biodiversity is also ongoing. And as doctors and healthcare professionals, we are contributing to this. So what are we currently doing about it? In 2008, the UK government signed the UK Climate Act, which committed the UK to reduce our carbon emissions from 80% of the 1990 baseline by 2050. It quickly became apparent that this will not be enough to prevent serious and lasting damage. And the Paris Climate Agreement went further, committing governments to limit temperature rise to well below 2 degrees Celsius. The Lancet Countdown is an international collaboration which examines climate change and also looks at what governments are doing to tackle it. And their latest publication in 2019 said this: the life of every child born today will be profoundly affected by climate change, with populations around the world increasingly facing extremes of weather, food and water insecurity, changing patterns of infectious diseases, and a less certain future. Without accelerated intervention, this new era will come to define the health of people at every stage of their lives. As doctors, we have a responsibility to tackle it. In May of last year, the UK government went further to declare a climate emergency and has committed to net zero carbon emissions by 2050. COVID-19 has given us some insight into the scale of this change that is required. The lockdown, the effect on the economy and manufacturing, massive reductions in air travel has resulted in a reduction in global carbon emissions. But the highest forecast is a 13% reduction if lockdowns continue for the rest of the year. You can see from this that achieving net zero is a massive task. So how much does healthcare contribute? American healthcare is probably the greatest contributor to their national carbon emissions, accounting for about 10%, whereas in England, we know that it accounts for about 6.5% of our national emissions. This graph from 2018, the Sustainable Development Unit, looks at carbon emissions. And here on the right-hand side, we can see that anaesthetic gases contribute about 1.7% of our emissions, not only from the NHS, but also from social care. And this is roughly the same as the staff commuting of all 1.3 million NHS staff. We can see here that patient and visitor travel to hospital has massive carbon costs. And unsurprisingly, the supply chain of our equipment and pharmaceuticals are the largest contributors. So what are we doing about it in the NHS? The main document that talks about this is the NHS long-term plan, and it talks about a 2% reduction in NHS emissions by transforming anaesthetic practices. And I ask you, since January of last year, have you seen a transformation in the anaesthetic practices in your department because of environmental issues? And if so, why not? I suspect that everyone here is familiar with the fact that inhalational anaesthetic agents have a greenhouse effect and that desflurane is the worst. This column here talks about the global warming potential over 100 years, with one being carbon dioxide. And we can see that desflurane is by far the worst gas from that point of view. Given that it has to be given in relatively high concentrations compared to sevoflurane and isoflurane to give a MAC of anaesthetic, the relative carbon dioxide production compared to sevoflurane is huge. We know from this paper by Vollmer et al. That these anaesthetic agents are detectable in the atmosphere and that they are on the rise. And we can see here the parts per trillion of desflurane is increasing, and this is in part due to the fact of its longevity in the atmosphere at about 14 years. So quickly, I'm just going to talk about calculating the environmental impact of general anaesthesia. I know many people have seen these calculators. There are two available. This is the environmental impact calculator created by Tom Pearce of the Royal College of Anaesthetists, and is also available online on the Association of Anaesthetists websites. We can do different calculations where we choose the second gas, whether that be nitrous or air. We choose whether we're going to do relatively high flows or low flow anaesthesia, and we can calculate the cost and then the carbon dioxide. And we can see this staggering amount of carbon dioxide, 117 kilograms per hour, when using desflurane at this relatively steady state, not incorporating priming of the anaesthetic circuit or the initial washing. Sevoflurane and isoflurane are better. If we get rid of the nitrous, which we know is bad for the environment, and replace that with air, reduce the flows to below 1, which would be by most people considered a low flow anesthesia, there are significant improvements, and sevoflurane starts to get down towards the 1 kilogram of CO2 per hour. If we go ultra low flow, which is my typical practice at steady state, but is not done in many countries, including America, where they have thresholds for this, we can see that there are some further carbon dioxide benefits, particularly with desflurane, having said that the benefit with sevoflurane is much less. 31 kilos of carbon dioxide is roughly equivalent to 100 kilometers in a modern car, and sevoflurane 1 kilo would be roughly equivalent to 3 or 4 kilometers in a car per hour. How about TIVA? Lots of people now are talking about the environmental benefits, but how green is it? This is the main landmark study by Jody Sherman at Yale and colleagues, looking at the different agents and calculating their greenhouse gas emissions throughout the entire life cycle. The top plot looks at the entire greenhouse gas effect and demonstrates that it is not manufacture, but the release of the agent into the atmosphere that causes the greatest damage. The plot below then compares the 4 drugs, excluding that agent release. And so we could imagine that this is a situation where we've got some gas capture technology where actually we release none of the inhalational agent into the atmosphere. And we can still see that there are major benefits with propofol. Spinal anaesthesia. So trying to calculate the environmental cost of spinal anaesthesia is not straightforward. Life cycle analysis of drugs in terms of their carbon expenditure is not routinely performed. However, the Gas and Greener app does allow us to do this for a sort of fairly traditional spinal anaesthetic using lidocaine for the skin and intrathecal bupivacaine, and we see that the amount of a kilogram of carbon dioxide to do this is calculated as extremely low, negligible, one might argue. How do we know this? Again, we know this by work from Jody Sherman and colleagues. This paper from Parvatka et al. Published last year performed a life cycle analysis. They call it cradle to gate. In the UK, it'd be more common to say cradle to grave, I guess. But the greenhouse gas emissions of 20 commonly used anaesthetic drugs. And we can see the scale here is actually logarithmic. It's not linear. 100 here, 1,000 kilograms per kilogram of drug, so quite a lot of drug. We can see propofols are actually low down, bupivacaine and lidocaine are relatively low down. What was a surprise to me is morphine, which I thought of as a fairly natural drug from poppies, is actually 1,000. Moving on to the drugs that we're particularly focusing on today, the short-acting local anaesthetic agents. We don't know the exact carbon dioxide cost of these drugs, but it'd be reasonable to assume that they're similar. And Synthetica informed me that their manufacturing plant is 100% renewable energy, and these sorts of things need to be factored in. Every drug has an environmental risk assessment before it is marketed, and we know from this that Prilocaine doesn't bioaccumulate, and that whilst it has aquatic toxicity at much higher doses, which is seen with many, perhaps most drugs when they put them in the water with fish, that the European Medicines Agency determined that it's an insignificant risk to the environment because the predicted concentration in the watercourse is so far below that toxic level. 2-chloroprocaine, on the other hand, has got such a predicted low environmental concentration level and low risk of bioaccumulation that it wasn't even required that they did any aquatic toxicology studies with the 1% preparation. But I understand with the aim to use 2% with peripheral nerve blocks that those studies are being undertaken. So what are the other benefits of spinal anaesthetics? We've all done spinals and general anaesthetics, and they tend to use less resource, particularly airway equipment. And this results in less waste. We've heard from Professor Harrop Griffiths how there's a benefit to use less PPE. And even in institutions now that are using reusable respirators, that tends to mean gloves and gowns not being thrown away. I've written here lower risk of aquatic toxicity than propofol, and we could argue that there is no risk of aquatic toxicity with local anaesthetic agents. It's certainly extremely low. And with propofol, it's important to say that the study there does say it's a low risk of aquatic toxicity, and that not only looks at propofol, but assumes that all of its metabolites are also potentially toxic to fish. So what should we mean by transforming anaesthetic practices? I think this means RA wherever, regional anaesthesia wherever possible, wherever it is a clinically sound decision and the patient consents to this. It means that when we do general anaesthesia, it's reasonable to avoid desflurane and nitrous oxide. We should always use low-flow closed-circuit anaesthesia with our volatile agents, and where possible, TIVA is almost certainly the greener choice. Spinal anaesthesia can help us facilitate ambulatory surgery. There are patients that are high risk for day case general anaesthesia, perhaps somebody with moderate to severe respiratory disease, who can safely be done in a day surgery environment with a short-acting spinal. It can improve theatre efficiency and patient flow. It can allow patients who choose not to have sedation to engage with their therapy, and this may reduce the need for outpatient follow-up and the journeys involved with that. We know from a study from Gebhardt and colleagues in 2018 that spinal anaesthesia is approximately half the cost of TIVA, day case anaesthetic. It's important that we just take a moment to think about what the benefits are of the environmental benefits of ambulatory surgery. And whilst these haven't been quantified, there are some fairly obvious ones. We know that there are fewer on-the-day cancellations, that's wasted patient journeys. We know that there are reduced complications of thromboembolism and hospital-acquired infections. Complications require resources and they have a carbon cost. We know that if you're at home, people don't need to travel long distances to see you, and we saw from that earlier graph that travel is a significant carbon cost within the National Health Service. And we know that ambulatory surgery can improve efficiency and have overall reductions in cost, and it's reasonable to assume that these are associated with reduced carbon emissions. COVID-19 gives us a significant opportunity. Spinal anaesthesia has major benefits for both, and keeping people out of hospital and having procedures in our day units or ambulatory surgery units is certainly a benefit. And I think this is a golden opportunity with all of the upheaval and change to pathways to redesign pathways and reconsider the local status quos, just like Professor Harrop Griffiths' colleague. The environmental benefits can be scaled up significantly when we do this in the thousands. This paper from just last month, entitled Green Journal, looks at the benefits of doing thousands of hip and knee arthroplasties under spinal as opposed to the US norm of under general anaesthesia, and the benefits are enormous. So my conclusions are that spinal anaesthesia is green, ambulatory surgery is desirable from an environmental point of view, and COVID-19 provides us an opportunity to change our established practice. Thanks for listening.
Will, thank you very much for a very enlightening talk. Not surprisingly, I've got a large number of questions that are coming through here. First question, which I think is probably relevant, is what is your definition of ultra low flow?
I'm not sure there's a consensus definition, but I did look that up, and less than 1 litre low flow, less than 0.5 litre ultra low flow, I think it's a fairly non-scientific, not a consensus, but it has been documented in the literature before.
Perfect, thank you. Another question, with TIVA, is there any information about all the plastics that's used and disposed of with regards to that environmental impact and how that compares with, say, other forms of anaesthesia?
So within that analysis by Jodie Sherman, she looked at the carbon cost of not only procuring, supplying the plastics, but also incinerating those plastics. So that is included within that carbon cost. I suppose there are potentially things which are not included. So the damage to the environment from particulate matter due to incinerating that additional waste would not be included. So we need to look beyond just simple carbon costs. And we know that when we make PVC and plastics, we use plasticizers, potentially dioxins, other harmful chemicals. So in terms of the carbon cost, yes, it has been factored in, and it is still an order of four orders of magnitude better. So it's still enormously better. But it's fair to say that some of the other environmental costs have not been factored in.
Okay. Another question, Will. Should we be discussing the environmental impact of our technique with our patients, and will this become part of informed consent?
So I think the answer to that question is similar to the professor's answer earlier. I think if the patient is considering both options, wants to know everything about it, it's reasonable to discuss the environmental impact. I think that we're in a fortunate position whether you're considering TIVA versus inhalational anesthesia or ambulatory spinals versus generals, that often that information is not relevant. We're not offering an inferior technique, and in many ways we may be offering a superior technique. But I do imagine that as the climate emergency becomes more emergent, that it becomes a bigger agenda, that people will be asking these questions. I think it's the Centre for Sustainable Healthcare are now talking about us considering the triple bottom line. We're all used to our hospitals saying, you know what, we're not going to provide that drug for you, or we might restrict your access to, let's say, Sugamadex because it's very expensive. We're not used to anybody saying we might restrict your access to that drug or that technique because it is very environmentally damaging. And I think that is going to happen over time. At the moment, it's certainly not my practice to say I'm offering this technique because of any environmental impact. I'm offering the best technique for the patient and then looking at how I can mitigate the impact of that technique.
And the final question, so we don't overrun, is how do you convince your colleagues not to use TCI sedation with regional anaesthesia, or should we be convincing our colleagues not to use sedation with regional anaesthesia?
I think Robbie Erskine will probably have an excellent answer for that in a minute. I think I wouldn't want to put people off making the transition, certainly from environmental point of view, of if people feel happier whilst they're trying to use spinal techniques for unfamiliar procedures, utilizing sedation. I think experts like Robbie will tell you that that is perhaps not required. And I think that from with regards to the topic, the content of my talk, from an environmental point of view, yes, that will have an environmental cost, but a small amount of midazolam or TIVA TCI, the environmental costs are relatively insignificant compared to the other.
Will, thank you very much for a really enlightening talk, and please stick around because we'll bring you guys all back at the end. Now it gives me great pleasure to introduce Dr. Robbie Erskine. Now, I remember when I started my consultant career in regional anaesthesia, attending a talk that Robbie gave a long time ago about ambulatory spinal anaesthesia. And at the time, I thought, I can't see there being any time when I need to use that, and how things have changed. So Robbie is a consultant anaesthetist at Derby. He has an interest in acute pain, ultrasound-guided regional anaesthesia, and in targeting spinal anaesthesia for ambulatory surgery. And it's really useful that we have you here for that. Robbie, I really look forward to what you have to say to us.
Well, thank you very much, Amit, and thank you everybody for joining, and welcome to you all from sunny Derbyshire. There we are. Right, I'm going to talk about ambulatory spinal anesthesia and why it's a really good and efficient choice, particularly in the present climate, but also generally for the future. So I'm going to talk a little bit about the pandemic, just to mention it in regional anesthesia, but that's been covered already. I'm going to talk about the state of play of spinals in the UK at the moment, and the evolution of short-acting spinals, really using knee replacement as an example over the last 30 years to see how it's changed and why the newer agents really fit in with this sort of surgery. I'm going to talk a lot about how to do it, because I think a lot of you probably want to hear that, and why it's the efficient choice. So I work in a regionally permissive environment in Derby. It's extremely easy for me to do regional anaesthesia. I've done it there for the last 25, 30 years. It's never a surprise when you do a regional anaesthetic here. We do a lot of spinals. I think we did about 15 or 16,000 spinal anaesthetics last year, just in our hospital. My talk's very experience-based. It's got a strong European bias. Apologies to those from elsewhere in the world who don't always have availability of some of these drugs. It's very much a how-to-use guide for spinal Prilocaine and 2-chloroprocaine, and it's got some practical hints and considerations. Here's a recent article for reference, which Will headed up. It has all the references in it, so if you want to find somewhere to find all the references, this is probably the place to go, and it's available in the literature. So the pandemic in regional anaesthesia, there is an increased regional anaesthesia interest. We know that. I think it's good. Some people might not. I believe you have to be a little bit careful rushing into doing regional anaesthesia when it's not something you're particularly well trained in or practiced at might be a disadvantage. But I think generally it's a good idea and people are more interested in it. There are GA risks. This has been talked about to staff, patient, and possibly the anaesthetist. There's a lack of theatre efficiency, which Will commented on, both Wills have commented on, and use of a lot of PP, and this can be avoided with regional anaesthesia. One area that's not been mentioned so much by anybody is the effect on the recovery area or the post-anaesthetic care unit staff. I think they're really at quite a high risk. You've got patients going there after general anaesthesia who are unable to stop themselves coughing for some reason and while they're waking up. And I think certainly they feel more at risk, and this has been an issue in our hospital. And I think regional anaesthesia is a benefit here too. And then there's patient involvement, which Will mentioned as well, and perhaps less follow-ups. So spinals in the UK, interestingly enough, in the awareness study years ago, 75% of patients who were supposed to be awake for awake surgery in the UK were done under spinal anaesthesia. That's 75% of all regional anaesthesia. It is the commonest and simplest regional anaesthetic. It's still underused. An observational study from Guy's and Thomas's, which Amit was involved with just very recently, when they looked at emergency surgery done during COVID, 46% of their regional anaesthetics were spinal anaesthetics. Spinals are a basic competency for all anaesthetists. Everybody can do a spinal. They have a low failure rate. They're highly effective operative analgesics, and they're suitable for all types of infraumbilical surgery, I would say. So I'm going to look at the evolution of spinal anaesthesia from the 1990s to the 2020s very quickly, just to, as illustrated by knee arthroplasty surgery. And I think they go hand in hand to illustrate it. So back in the 1990s, in Derby, we used spinal bupivacaine. We used an epidural for post-op pain, fantastic analgesia, long length of stay, 8, 7, 10 days. And the patients had a catheter, an intravenous line, very heavy legs. It made physio difficult. And there were problems associated with that, certainly not an enhanced recovery regime. We moved on. In the 2000s, we used spinal bupivacaine still. And then we went for femoral and sciatic blocks and dropped the epidural. Fantastic analgesia, slightly shorter length of stay, still had a catheter, still had an intravenous line, and they had a very heavy leg, which made, again, active physio a lot harder. In the 2010s, the concept of enhanced recovery came in, and we started to use what we call analgesic spinals. So this is a low-dose bupivacaine spinal with some opioid in, usually in the UK, fentanyl. We used local infiltration anesthesia for pain relief afterwards, and often they had a propofol infusion, which has just been alluded to. And I think this is often used because the low-dose bupivacaine spinal might not have been quite adequate for this surgery, certainly for hip surgery, where it is higher and less easy to catch. So where are we in the future from now on? Well, I'm starting to look towards using more normal volume spinal anesthetics. So using normal volumes of the correct spinal to suit the length of the operation. Using Prilocaine for a lot of these procedures, and even chloroprocaine for some quicker day case knee replacements. We're using local infiltration analgesia for post-op pain, and I know this is one of the questions somebody asked. What do we use to take over from the spinal? And this is absolutely fundamental to the management of low-dose spinals, low short-acting spinals. We use femoral triangle blocks or adductor canal blocks. Some use IPAC blocks. And I would question, as this has been alluded to already, the need for sedation. There are other ways of managing patients who are anxious. They may receive a small dose of a benzodiazepine prior to the spinal, but often once they're settled in theatre, they might not need any sedation. You can talk to them. Patients are very interesting people and always fascinating. So how we do it? Well, we've got three choices essentially in the UK. We're very lucky. We've got low-dose bupivacaine, plus or minus an opioid for pain relief and maybe to help with the low dose of bupivacaine. We've got hyperbaric Prilocaine, and we've got isobaric 1% chloroprocaine. I think bupivacaine may be too much for a lot of anesthesia. You get heavy legs. Retention is a significant risk for these patients. Opioids cause pruritus, very commonly, particularly fentanyl, even in low dose. they can have a delayed discharge, which is very frustrating for your day case staff. And I think you should avoid it if at all possible for procedures less than 120 minutes. So the principle is, if a 3-hour GA is too long for a 60-minute procedure, I would say a 3-hour spinal is also too long for a 60-minute procedure. So spinal has to suit the procedure. And we're mainly talking here about Prilocaine and 2-chloroprocaine. These are game changers. They've made a real difference to us, certainly in Derby. I think they're starting to change around the country. So heavy Prilocaine, it's widely used in Europe for over 10 years. Sadly, not in the US or Australasia. It'd be lovely if they could have it. It's of intermediate spinal duration. It's licensed for 90 minutes of actual surgical time. I don't know if that includes the time from the spinal going in to going to theatre, which can be quite long. It certainly gives you 90 minutes of surgical time. But I have found in practice that for particularly knee, foot and ankle surgery, you can get up to 120 minutes of analgesia with this particular drug. I would say just be careful for hip surgery, which involves higher dermatomes, and you might have more of a problem with this. But certainly 90 minutes is very achievable. So the hyperbaric property allows for manipulation of height of the block, which is really handy with Prilocaine, and I'll show you how that works shortly. There's evidence of increased cardiovascular stability compared with bupivacaine, and this has been shown in elective lower segment cesarean section. It fills the gap between bupivacaine and chloroprocaine beautifully, and it allows day case surgery without the need for intrathecal opioid. So what about chloroprocaine? Well, this is isobaric. It's been used in the UK since 2013, and in Europe for longer. It's been licensed in the US too since 2018, although they have used it off license for many years there. It is of short duration. It's licensed for 40 minutes of actual surgical time. But I find, particularly when doing knee and ankle surgery, you can get up to 60 to 80 minutes out of this drug. Again, a little bit careful with hip surgery, which does require a higher block for achievement of good surgery. So I'd be more careful there. It's less easy to manipulate the height. I would say it rarely goes above T10 for that long, but there've been no case reports of urinary retention, and the patients feel better. They don't get that sort of perineal lag that sometimes patients get with the heavy drugs. This is all about targeting your spinal to suit the procedure and the surgeon. And I asked certain pragmatic questions when I take an approach to decision-making about these drugs. My first question is, do you just need a saddle block? This afternoon, I was doing an emergency list. We had a patient with a perianal infection, an abscess, and a saddle block was ideal. If you don't need a saddle block, do you require a very high block? For instance, if you're doing epigastric hernia repair, it's a day case under spinal. Should you not require a block really above T10 for any particular reason? The next question is, how long is the procedure going to take? If it's very short, or is it intermediate? No opioids are particularly required with these drugs, and they're not licensed for use with these drugs. And I would say that what we're dealing with here is a per-operative analgesic spinal, only for the operation, as you do with the GA. But it's really, really important point. You must remember that you must think about following on with a regional block of some sort or multimodal analgesia to take over from your spinal when it wears off. Remember, spinals are not there for post-operative pain relief. They're there for the operation, and you must think about what to do afterwards. So this is our aid memoir for the anaesthetic room. This is what we published in our article. It's a version I designed back in 2015. It's a great help when you're starting to use these drugs in the anaesthetic room for colleagues. It stops them phoning you up every 5 minutes and asking you what you use for what. So it's very handy. There is a version in the Synthetica booklet and also in the B. Braun literature. So the initial question is, do you want a saddle block? In which case, use a small dose of Prilocaine, and the patient can be ambulatory very soon afterwards. Extremely effective. If you want a block above T10, use a good dose of Prilocaine, using its hyperbaric nature to achieve what you want to achieve. If you don't want a block above T10, it comes down to how long it's going to take. And I would say an hour is a pretty good way of dividing the two drugs off. So if it's greater than an hour, I'd choose Prilocaine. And if it's less than an hour, I'd choose chloroprocaine. And this is the sort of decision that we're making every single day. So how does it translate to a typical theatre session? So this is your low-dose bupivacaine with opioid, the traditional approach, an arthroscopy using bupivacaine, an ACL with bupivacaine, and a total knee with bupivacaine. This may be using low-dose bupivacaine, but they still get a very long time to block regression. But the surgical time, as you see, does not really suit the length of the spinal anesthetic. So this is what we see when we get a targeted approach. You're using chloroprocaine for your arthroscopies, a much shorter regression time, much quicker ambulation, much happier day case staff, much happier patient. The ACL, you might use Prilocaine. We're moving on with this, and some of them are getting chloroprocaine, and I'll talk about that. And the knee replacement at the time was still getting bupivacaine. But again, the spinal suits the length of the procedure. So if you're a first-time user, I would say follow the guidelines on the decision-making chart. It really helps to get things started. They are guidelines, you'll develop them with time. Try Prilocaine first if you're a bit unsure about using these drugs to get yourself confident, and be generous. Remember, these are they're not low-dose drugs, but they're short-acting drugs. So the concept of low-dose anesthesia for a lot of these drugs, unless you're just doing a perineal block, is no longer there. So give a decent dose, but of the correct drug. Don't bother with opioids. They're not licensed, and I don't think they're particularly necessary. And also know your surgeon and your surgeon, and expand your use as you become more confident with these drugs. So in Derby, for instance, over 5 years, we've done actually now more than this, but we did a study with 625 knee arthroscopies, 20 to 80 minutes spinal to dressing time, very low failure rate. That's probably just technical failure more than anything else, and no GA conversions and no urinary problems, and very popular with patients. So a quick bit on what do I choose? Well, know your surgery, know your surgeon. It's really important to be part of the team. When you have your WHO meeting at the beginning of the day, chat about what you're going to do, find out what the surgeon's going to do, and tell him you're going to use a short-acting drug, and he needs to be in theatre operating, or she. So for a simple ACL, if you're just doing an allograft, 2 chloroprocaine might be entirely appropriate. But if the procedure is a little more complicated, you have to think about maybe using Prilocaine if there's a lateral tenodesis or meniscal repair that might take longer. Ankle fixation, like I did on Sunday. So if it's just a lateral fixation only or a medial screw only, 2 chloroprocaine could be ideal. More complex, choose Prilocaine. As I said, for perineal surgery, a saddle block is all you need. And I would choose 1/2 ml of Prilocaine for its porosity. Extremely effective for all forms of surgery in this area. Inguinal hernia, very common operation. If it's bilateral or large, choose Prilocaine. If it's unilateral, you can use 2 chloroprocaine. If you're doing umbilical hernias, it's a great operation to do under spinal, very effective. Ureteric stents, again, very effective under spinal. But you really need to choose quite a high dose of Prilocaine, so its porosity takes advantage of its ability to get higher. So recent advances, well, hemiarthroplasty, dynamic hip screw. I'm using Prilocaine for most of these patients now. Very effective. It's a quick onset. I would say it's cardiovascularly more stable. Hip screws, 2 chloroprocaine. And remember, they get a less prolonged sympathetic block in recovery. And this can be really handy when you are not with the patient in recovery and they need their blood pressure managed. I think these patients really benefit from that. So going forward, uni knee arthroplasty or simple knee arthroplasty, I would often use 2 chloroprocaine. A trickier knee arthroplasty, perhaps Prilocaine. A primary total hip, I would still tend to use bupivacaine at the moment. But if you've got a very slim patient, a particularly fast surgeon, I think Prilocaine is extremely effective. And I've used this quite a lot. This is my trauma list. This is real anesthesia from Sunday afternoon this week. Short femoral nail, cannulated hip screw, tibial spanning X-fix, washout of a knee laceration, and fixation of an ankle. And you can see I use Prilocaine for the first one, chloroprocaine, Prilocaine for the third, chloroprocaine for the fourth, and Prilocaine for the 5th case. You can see I've written some blocks down as well. I always make sure that I have a block in place to take over from my spinal when it wears off. And those are the lengths of surgery we achieved. Some were done by trainees and some were done by the consultant. So this is real life. So why is spinal anesthesia the efficient choice? Well, a lot of this has been discussed. There's no aerosol generating procedure, increased safety for everybody. It's time saving and it's low cost. I think you should offer sedation if appropriate. Why not? And allow the patient to change their mind at any time. If they want to be sedated and you haven't done it before, make them part of the team, make them part of the decision making. And I think this is really fun. Match your spinal to the procedure. They can keep their dentures in. I know this may sound like a small thing. For a lot of patients, it's really, really important. They can drink clear fluids till they come to theatre. I even give them fluid to drink in theatre. Patients may observe the procedure or discuss treatment with the surgeon and perhaps avoid a follow-up visit too. There's no wake-up time or air removal time in theatre. I think it's safer, particularly for your recovery and PACU staff, and they have a shorter recovery stay. They rapidly immobilize and they discharge quickly. So in summary, spinal anaesthesia is the non-regionalist's regional. We can all do it. It's simple, it's safe, it's effective, and it's efficient. And thanks for listening, everybody. I hope you've enjoyed yourselves.
Robbie, thank you very much. That was excellent. As you might imagine, there have been a ridiculous number of questions that have come through. And in interest of keeping the webinar moving, I won't ask all of them. One very quick question for some of our colleagues who may not be aware of it. What's an IPAC block, please?
Oh, there we are. So this stands for in between popliteal artery and capsule of knee. So it's an ultrasound guided, very peripheral analgesic motor sparing block of the posterior capsule of the knee. So it's where the supply comes into the back of the knee, which provides pain relief for a lot of knee surgery. Highly effective. It's been a real game changer for me in major knee surgery in the last couple of years. A massive difference, massive difference.
And when you talk about low dose bupivacaine, how low is low dose bupivacaine?
Oh, I'm probably talking 1.5 mil to 0.5%. So that's what, where are we now? That's about 7.5 milligrams or less, I would say. It's a difficult one to be precise about because different people have different views. But I would say I pay probably 7.25 milligrams is probably what I'm talking about. Yeah.
And have you any experience with diluting bupivacaine with saline, diluting it down?
I never add anything to it. I think there's a potential for error here. I think there's a potential for infection. I think it's unnecessary. I know a lot of people do this, but I think the effect is perhaps far better, more dependent on how fast you inject or the position you put the patient in. Certainly. Okay.
Final question, when should I add opioids to my short-acting spinal?
Yeah, that's a good one. As I mentioned, I don't think it's necessary 95% of the time. There is one exception to that, and that is when I'm doing pelvic surgery, for instance, vaginal hysterectomy, pelvic repair, that sort of thing, or when I want a short-acting spinal, but I want some post-op pain relief, I would add diamorphine. That's my drug of choice. But that's not really there to improve your spinal. It's there to provide you with post-operative pain relief for these patients. So that's when I'd use it. Otherwise, I don't bother anymore. I really don't bother.
Robbie, thank you very much for an excellent talk. And now we move on to our last talk of this webinar, and it gives me great pleasure to introduce Dr. Ben Fox. Ben is on the REUK Council with me, and he was on the AAGBI Board of Directors, where he's contributed to several national guideline documents. He's very passionate about regional anaesthesia. He's co-authored BADS handbooks on spinal anaesthesia for day surgery and upper limb nerve blocks. He was also the program director for the regional anaesthesia master's degree and has taught on many courses nationally and internationally. Ben, it's a great pleasure to hear you talking to us about implementing spinal anaesthesia, ambulatory spinal anaesthesia in 8 practical steps. Thank you.
Thank you, Amit, for the warm welcome. Yeah, hi, I'm Ben. I'm basically going to go through an infographic that we put together just to kind of really act as an entry for this type of modality. In terms of who I am, why am I talking to you, affiliations, or if I've been receiving money on the side. I'm the course director of the regional anaesthesia master's degree. I have contributed to the Synthetica handbook, which Robbie's already referred to. I've also received honorarium from Synthetica, so sold out. I have co-authored the British Association of Day Surgery handbook on spinal anaesthesia, and I'm on the RAUK board. So what am I going to talk about? I'm basically going to go through this. So this is available on the RAUK website. Now, some of you would think this guy's an idiot because from the poll that you did with Amit, some of you are already doing this. So you might look at this and go, he's using way too much. this is meant to be like an entry just to help people, and then you can then refer to the booklet and also Robbie's talk to try and like get your practice to where you want it. So the main message for my talk is going to be keep it simple. Just keep it simple. I can do it, and I'm an idiot, so it's idiot proof. First point. I'm asked quite a lot, how do you convince patients for this particular technique, spinal anaesthetic? I would say I don't try to convince, I try to just give the options, and Will Harrop Griffiths gave this in his talk a bit earlier on. You give the patients the information. You may well tip the scales in terms of what you think is your opinion of the benefits for that patient, but I'd never try and be a used car salesman. The secret, I think, is actually getting the surgeons and your pre-assessment staff on board. And that basically allows us to plant the seed, or this is the pip, of that thought of the anaesthetic much earlier on in the patient journey. So in outpatients, if they're given a wide range of options that they can perhaps potentially have, they might start thinking about it. I think you're on a hiding to nothing if you try and convince someone or gang press someone into having a particular anaesthetic on the morning or the afternoon of surgery. What kind of operations are we actually doing with ambulatory spinal anaesthesia? This is a word cloud, and you're probably quite familiar with word clouds. The size of the font is how popular something is. This is the last 100 spinals we've done in our day case unit, and you can see the kind of regular players that are coming up. So cystoscopy and arthroscopy are kind of front and center. But you can see all the weird and wonderful things that we've also been doing with spinal anesthesia as well. Coming back to the conversation that the surgeon puts to the patient early on, when we first started talking about this webinar, I kind of had this idea, it's not a novel idea, but I had this idea for at least my department of producing a little anesthesia in a nutshell guidance, so that surgeons just could kind of make some form of reference in terms of the anaesthetic options. Now, don't worry about all the details there. I've actually put it on my Twitter account, so if you have a look, you'll be able to see the full detail. This is just kind of like the kind of like the nuts and bolts of it. This kind of gives you a bit of an idea of the information that perhaps a surgeon can tell patients that might kind of convince them of a particular technique for their anaesthetic, and it plants that seed nice and early on. So we say that we've managed to get some patients on board. They want to have a spinal. What about the technique? How are we actually going to put our needle in? As I said right at the beginning, keep it simple. So whatever you're most comfortable with, most anaesthetists I see like a sitting spinal, so just sitting spinal. The orifice of the needle, just have it facing cephalad, and then just lay the patient supine. With the doses I'll be talking about, you don't have to do any weird and wonderful positioning of the patients to kind of coax it into action. In terms of the orientation of the orifice, this is a nice little video that basically shows that the injectate, when you inject normally, it's along the axis of the needle. It doesn't do this lovely little kind of like right angle towards the nerve, so you can't just angle it to the left and it's just going to do a right turn or left turn. Yeah. Now some people say, I don't want to do a spinal because of the time it takes. This is a setup that we've got here in terms of getting patients set up for having a spinal anaesthetic, little video that I put together. But not all spinals are created equally. So even though the setup here is quite nice, and we get this 5 minute, 30 seconds, you sometimes see that the spinal itself doesn't go to plan. We've got some patients that we want to put a spinal in. We've actually got the needle in, so what drug do we do? In terms of the infographic, what we've put up here is just 2 doses, just as a kind of, as I said before, an entry level. So we've got 5 mils of 1% chloroprocaine, that's 50 milligrams, and we've got 2.5 mils of 2% heavy prilocaine, which is 50 milligrams. And what I'm going to do in the next few slides is talk about the dose, and also you'll see here I've got expected ambulation, and we'll talk about how we've kind of come up with those figures. So hyperbaric prilocaine. This is some data that I collected with one of my colleagues from my hospital a few years back. 82 knee arthroscopies. We looked back retrospectively, so it's almost like a kind of an audit type project, and we looked at the median dose, and it was 1.7 mils of 2% solution, so 34 milligrams. Now note this was with fentanyl, which I stress is an off-label use, but that's the kind of where colleagues in my department were at with this. The median time from spinal to discharge was 3 hours in these patients. Now note there is a wide range here from 1.5 hours, which is pretty impressive, to 6 hours. Now, those times have been shown in literature. So Campanovo, in one paper where him and his team were looking at 40 milligrams heavy prilocaine, 60 milligrams heavy prilocaine versus 60 milligrams plain prilocaine. And if you get the data for the 40 milligrams heavy prilocaine, in terms of spinal to discharge criteria was 3.5 hours, which is pretty good. And it kind of almost follows our data as well. Now, this is a really lovely paper by Emmanuel Guntz and colleagues, and they did a study for the ED50 and ED90 of heavy prilocaine for knee arthroscopy. And they found the ED90 was 38.5 milligrams. And in the second part of their study, they used 40 milligrams of heavy prilocaine all by itself. And they found two things. One, in 4 patients, they needed some form of supplemental analgesia for the tourniquet and for the scopes. So this is why I've kind of just pushed up this entry-level prilocaine to 50 milligrams. And also the other point to raise is the average duration was pretty much in keeping with our data and also Campanovo's data. If we move on to chloroprocaine, this is also data from our department. This was presented at ESRA back in 2014. This is really when chloroprocaine was kind of first getting onto the market in the UK. So 57 knee arthroscopies, and the dose was 40 milligrams. We found that the median time from spinal in to ambulation was 2 hours, with the range there 1.5 to 2.5 hours. 3 patients had pain with this, and 1 patient needed to be converted to a GA. Interestingly, I was the guy that did the spinal that got converted to the GA. So I said I'm presenting something that's idiot-proof, and that's kind of evidence about me being the idiot. In terms of other data, Campanovo, who was looking at chloroprocaine versus bupivacaine 10 milligrams, with 50 milligrams of chloroprocaine, they found from time of spinal to discharge was 2.5 hours. So one question that I've had a few times is, well, how does this all compare to general anaesthetic? Surely a general anaesthetic, a quick general anaesthetic's quick in terms of time from anaesthetic to discharge. If we have a look at a list that is going on regularly in my hospital, so every other Tuesday morning we have a knee arthroscopy list with one particular surgeon. It's relatively the same theatre team, it's the same environment, so same setup, and this is going to reflect real life practice. So this isn't a study where someone's trying to get people out of the bed. This is kind of when the bosses aren't really looking. So don't necessarily judge us in terms of this, but it should give a nice comparison of the GA versus spinal. The range for the GA was from time of spinal, so this includes the surgical time and recovery time from spinal to going home range from 3 to 7.5 hours. Now, if we look at the spinal group, it's pretty similar, 3.5 to 8.5 hours. Now, I know you're thinking, God, what are they doing? But this doesn't take into account anything in terms of travel arrangements, people waiting for cars. And actually, you can see that the mean difference isn't that, well, the difference between the two means isn't that much. It's an hour in it. So when people say spine is going to take ages, it's going to wear off, it's not going to wear off. It's not that bad. And if you've got the GA the proponents saying, well, an hour is a lot of time, well, actually, I know Robbie's, the surgeons that Robbie works with, copies of one of the, well, doesn't copy, but does the same thing as one of the surgeons I work with, in that he doesn't do a follow-up appointment for the patients that have had a knee arthroscopy. He takes them on a little tour, like an underwater documentary of the knee, shows the problem, shows what he's done to it. The patient gets that information there and then, and he doesn't schedule an outpatient appointment. Whereas the GA patients, they all come back a few weeks later, and that even will have an impact on the environment, as per Will's talk earlier. So drugs, keep it simple. 50 milligrams chloroprocaine, as Robbie said, licensed for 40-minute operations, and we said 2 hours in terms of looking at ambulation. And then in terms of Prilocaine, licensed for 90-minute operations, 50 milligrams, so 2.5 mils. And ambulation, you're looking at somewhere about 4-hour mark, but it may well be somewhat shorter than that. So next bit, we've got our drugs in. So what do we need to keep an eye on? The one thing we want to keep an eye on is that we don't cause a mechanical obstruction because we give the patient too much fluid. So limit the fluid to 500 mils. Don't put 1 litre bags up for day surgery. And patients do not routinely need a catheter. Now, this is arguably, no, next slide is going to be arguably one of the more important slides, but this is a very old paper, and this actually paved the way for our own bladder management pathway within our department. And I'll show you that pathway in a second. And we have not encountered retention from a spinal with patients which don't have any other risk factors, so low risk patients, so the fit, healthy patients having the arthroscopy, we've not caused retention because of the spinal. And we are strict with the fluid, but not too strict. So if a patient needs fluids, by all means, give it to them. In terms of the bladder pathway, low risk patients, we've actually said, and we've said for quite a few years, well over 10 years, they don't have to void before they go home. And it's the more at-risk patients where we actually have to be a little bit more careful about. Now, don't worry about all the details which is in this slide. There's a more abbreviated, shortened version in the handbook, much more simple. The main thing to really kind of take home from this is we've got a risk factor stratification, so what puts someone at risk. And if they're at risk, the main thing that we're going to be doing is, can you void or can you not void? And then ultrasound scan of the bladder. And the addition that we've made to our bladder management chart is actually asking for an international prostate score for certain patients depending on what way they go. It's quite fun. It's a talk all in its own right, and colleagues in my department actually presented this at BADS last year. I've put my Twitter account here, and I've got this like this picture on my Twitter account. But also, if you want to find out more, and I can give you the presentation we gave to BADS about this very thing, email me. My email's coming up in a second. Or just look in the handbook for the more abbreviated version. But really get something like this in place before you're doing lots of spinals within a day case environment. So next point is thinking about hypotension and other mischief that spinals can cause. Maintain venous return, and whatever you do, don't sit the patient bolt upright because you will come to mischief, as the idiot has experienced once before or twice before. We looked back at our last 100 patients, and I'll go through what we found. We had one very impressive vasovagal episode in recovery, which looked more like a kind of nasty Basel-Jarisch reflex of horribleness. And basically, the patient had been sat bolt upright immediately after coming out of theatre. You've got to treat this anaesthetic with the same degree of respect as you would a general anaesthetic. So just because it's local and the patient's chatting to you, you've still got to be quite vigilant. So the patient still might need some form of glycopyrrolate, metronidazole, or even ephedrine. And I'll say again, avoid dehydration and avoid this sitting up too quickly. And so we want to keep them wet, but not too wet. So just somewhere in the middle. So 500 mils is quite nice. So when can a patient go home after a spinal anaesthetic? Early on, when my predecessors really kind of worked on this within our department, the thing that they looked at was straight leg raise. Now, the problem with that is motor is one of the first things to come back. And actually, you can straight leg raise, but if the sensation and proprioception haven't yet come back, and they do come back later, you may well get into a muddle in terms of instability. So check sole sensation and check proprioception on the big toe, and then you won't get into mischief. And then lastly, like we do all the time, we audit everything. And if you're going to introduce this into your practice, I'd say audit. It's quite a cool project for any juniors that want to kind of a project, or anyone else that wants a project. But I would really advocate the follow-up. And what we do in our department, and I don't know if Robbie will add in later what he does, but we follow up all our patients in day surgery who have had any kind of block. So any upper limb, lower limb block, they get a nurse's phone call the following day, or if they can't get through, the day after that. And this includes spinal anaesthetic. And it's usual kind of questions that you would be asking the patients that have had a obstetric spinal anaesthetic. So have you got a headache? Have you got any problems with your legs? How's the bladder doing? And then all the kind of like the nice questions as well in terms of would you rate your anaesthetist? No, it's would you have this anaesthetic again if you got the chance? Which is quite cool. So I really kind of advise going down this route, having some form of follow-up and getting that in place. So, oh yeah, last bit, right at the end of the infographic is basically a hyperlink to the handbook that Robbie, myself, and everyone else has been basically making reference to. So it's a nice resource. And I see Amit, so my time is up. Sorry, Amit. This is me. That's my email. This is recorded, so you'll be able to get my email later on. That's what I've talked about. And the main message is keep it simple. You've been great.
Ben, thank you very much. And just for the audience, I just wanted to highlight Ben designed that whole infographic himself. So he put a lot of thought and effort in that in order to distill the core principles that we all wanted. So Ben, we really appreciate you doing that. As we are getting towards the end of the webinar, I'm going to basically take a couple of questions that have come up, which are probably most relevant. Any tips and tricks to get the surgeons on board? A lot of them in our institution struggle with the idea of spinal blocks and having patients awake during surgery.
Taking the example I might have mentioned, I can't remember if I did, but the knee surgeon that I commonly work with, he doesn't have that follow-up outpatient appointment, and so he argues it's a much better quality of care for the patient, but also he then actually just gets to see new patients. He's not doing a follow-up clinic just to see patients where he knows, well, trying to explain something he did a few weeks back. He's able to give all that information there and then. Obviously, some surgeons might not like that. They might like the kind of easy life of just doing lots of like follow-up outpatient appointments. In terms of the patients being wide awake, I think that the easy thing to do there is to perhaps add in some sedation. I know that it's a bit of a contentious topic, but if it means that the patient's going to be, well, it means that the surgeon's going to be a bit happier, a little bit of sedation will just kind of help to grease the wheels.
Thank you, Ben. And I think the last question, there are so many questions, so I think we'll probably email them to you to see if you can give us your answers, then we'll email them out to all registrants afterwards. So how do you go about mobilizing the patients? Do you have specially trained nurses for doing that? So you wait for hallux proprioception, straight leg raise, and sole sensation, and then you just get them up safely, or is it slowly, or is there a specific pathway you have?
Yeah, we don't have a pathway, but basically, the guys in our department have been doing this for about 16 years. So I think the first BADS handbook was published, I wrote it down actually, 2004. And so it wasn't just the anaesthetist, it was the nurses with this as well. So it's almost been like a kind of a hand down through generations of what to do. And so basically any time the patient's going to get up to move, the nurse will be there to actually assist them. And as you said, that there is criteria that the nurses will assess before the patient is actually mobilized.
Perfect. Ben, I think we're going to call it a close there. So thank you very much for that. And I think we're just going to close up the webinar with a poll. So we asked you a question right at the beginning of the webinar, and we'll invite our other speakers to come back on screen whilst we release this poll. So how confident are you to use short-acting spinal anaesthetics, having listened to our fantastic speakers today? Let's see if there's any difference in the numbers from before. I believe we had about 40% saying they were very, and then probably somewhere in the region of 60% saying not very or not at all. So we are getting our numbers through as we speak. And there we go. So there we go. That's. I think I call it a swing. I think Professor Harrop Griffiths is all about swings. He would agree that was a swing, right?
I would absolutely agree that that's a significant result, that you have moved forward the science and the art of regional anaesthesia this evening. Well done, guys, all of you speakers, and Amit, brilliantly chaired.
Fantastic. And we didn't talk about PEX 25 or Tequila 16 or anything like that. So the one thing before I draw the full meeting to a close, I wanted the opportunity to get all the speakers on here. There's one question that's come up repeatedly relevant to COVID-19, which is, do we need to use full PPE when citing a spinal anaesthetic, certainly an ambulatory spinal anaesthetic? Can we afford not to? And your thoughts?
I would say no.
So you'd say we don't necessarily need to do gloves, gown, mask, hat, the full works. Is there a
Okay,
minimum acceptable?
Okay, I think you need to wear these days gloves, gown, and a cap, but I wouldn't say you need to wear the FFP. Is it the 5 mask, the high-level mask for that? Yeah.
Professor Harrop Griffiths.
Can I just say there's no such thing as full PPE. There are droplet precautions and there are airborne precautions. If the spinal is being given by somebody who's confident in doing it, with a patient unlikely to cough and misbehave during the procedure, with a very low chance of conversion to general anaesthesia unexpectedly during the procedure, then it is reasonable for everybody in the room, after discussion at the briefing session, to wear droplet precautions rather than airborne precautions. We need to remember that a lot of people out there are using spinals for obstetrics, and in those procedures where there's a high chance of conversion to GA because of patient or pregnancy-related issues, it is reasonable, as the Obstetric Anaesthetists Association has said, to actually wear airborne precautions. So it's not an easy one to answer. It depends, but a lot of the time you can just wear droplet precautions.
Fantastic. And then the last question, whilst I've got you all on board here before we finish, is do you have any strategies in place to prolong anaesthesia or analgesia if the surgery goes on for more than 2 hours? So you've planned for something that will fit within that time window, and what happens if it's a trainee surgeon or things don't quite go according to plan? We bring out the propofol. Prof?
I do quite a lot of vascular. Quite a lot of these are EVARs, all very potentially long, lower body procedures, and I have a fairly low threshold for using continuous spinal anaesthesia. I don't know what the other panelists think, but if there is a reasonable chance that it could be prolonged and there is a particular benefit to the patient with spinal anaesthesia, always remember the possibility of continuous spinal anaesthesia. Otherwise, plan B is kind of always a general anaesthetic, and Robbie will jump in very soon and say that if you add really good blocks to your spinal, even once the spinal's gone, the blocks will continue. Robbie, cue you.
I totally agree. 2 points I would have. One is, just as Will has said, I think it's absolutely fundamental part of short-acting spinal anaesthesia to use it just for the length of the operation and to use blocks to take over. And I think this has a huge benefit for these patients. Second point is in relation to vascular. I totally agree. I would use continuous spinal or even an epidural combined with the spinal. But I would also consider using 0.75% plain bupivacaine for those patients, because I think it's actually been really useful for them, particularly the longer FEVARs and EVARs. But I think, no, I completely agree with you.
Well, listen, at this point, it gives me nothing else that remains for me to do other than to thank William, Will, Robbie and Ben for your excellent talks. I very much enjoyed listening to all of them. I hope everybody at home has. I've got a holding slide up here. This is to remind everyone to save the date. Next year, RAUK 21 is going to be in Sheffield, the meeting that we cancelled for this year because of COVID-19. Save those dates, Wednesday the 5th and 6th of May 2021 in Sheffield. going to be great fun, and we will be announcing speakers as the year goes. So thank you very much. I hope you've all enjoyed what I think has been a really educational webinar. Stay tuned. There are some more RUK webinars due to come at some point in the future, so we will announce those shortly. Thank you very much, everybody. Enjoy yourselves. Take care. Be safe. Thanks very much. Bye-bye.